Welcome everyone to the Innovations 2021 webinar organised by Nevro Extend, and that's Nevro's professional education group. My name is Quentin Manley, but everyone calls me Q, so please feel free. And I'm head of the international team here at Nevro. The only thing that qualifies me for in this meeting is to act as the master of ceremonies and the timekeeper, but that's fine because our faculty today have more than enough technical expertise and knowledge to make up for my own woeful lack in that regard. I'll introduce our esteemed panel of speakers in just a moment, but first I want to welcome our audience. Innovations is an international event, so we have participation from around the globe. In Europe, we have attendees who have only just finished their morning coffee and are looking forward to a full day of work. And we have a large audience in Australia who are looking forward to their first glass of wine for this evening. Given the subject matter that we have on discussion today, we're attracting a very diverse range of specialties. And a quick look down the attendee list shows we have a lot of pain physicians, podiatrists, neurologists, endocrinologists, diabetes educators, chronic care specialists, neurosurgeons, vascular surgeons, aged care, sports medicine, occupational therapists, and physios. And I think that's a tribute to the diversity of the issue that we're discussing today. You know, I'm always conscious that an hour of a busy clinician's time is not a small investment, and so I'm honoured that you decided to spend an hour to attend this meeting, and I'm mindful of our obligation to deliver you a valuable educational experience. So thank you very much to our audience for your time and attention. Now, about the subject of this meeting, it would be hollow of me to pronounce upon the burden of painful diabetic neuropathy, the burden of suffering of disability for patients, and the burden of our collective healthcare systems. It'd be hollow because of me, because all of you see and treat these patients every day and know the issues full well. You'll also know the treatment options for these patients are neither plentiful nor wildly effective. And so there's understandable interest in the growing body of evidence behind any addition to the armamentarium with which to treat PDN. Recent published work looking at spinal cord stimulation for the treatment of PDN is causing a storm of interest, and with that in mind that we've invited a panel of 4 clinicians of worldwide renown in this field to discuss the topic. We have 4 presentations, one by each member of our faculty, followed by a panel discussion with questions from the audience. And to keep the timing and the technology dependable, the presentations have been pre-recorded, but 3 of our panel of 4 presenters are here in person to add comments and answer your questions live. You can ask your questions and also vote for your favorite questions using the window on your portal, and I'll serve them up on your behalf after the presentations for a lively, I think, discussion. One final point is we do have a house rule, and the house rule is that if any one of our audience can ask a question which completely stumps our panel, then everyone gets to take the rest of the day off, except in Australia, of course, where they've had the day, in which case they get to take tomorrow off. So those are the rules. So start thinking of your questions and I'll introduce our eminent panel. Dr. Sarah Love-Jones is a consultant in anaesthesia and pain medicine at North Bristol NHS Trust. After graduating from King's College Hospital, University of London, she joined the Royal Army Medical Corps and served in Cyprus, Kenya, Bosnia, and Northern Ireland. She went on to gain a registrar post in anaesthesia and pain medicine and was appointed consultant at North Bristol NHS Trust in 2009, where she took over the neuromodulation service shortly after. Dr. Love-Jones is the lead clinician in the Neurosciences Directorate for the Specialised Tertiary Referral Neuromodulation Service and is an elected council member of the British Pain Society. She sits on the NHS England Specialised Pain Clinical Reference Group, is an advisor for the NICE Interventional Procedures Programme and examiner for the ESRA European Diploma of Pain Science. Unfortunately, Dr. Love-Jones isn't able to be with us here today, but her presentation I'm sure you'll find fascinating. Dr. Vahid Mohabati is the first of our brace of experts from Australia. He has an extensive background in emergency medicine, general practice, pain medicine, and palliative medicine. He's been awarded fellowship of 3 colleges in Australia, the Royal Australian College of General Practitioners, the Royal Australasian College of Physicians, and Royal Australia and New Zealand College of Anaesthetists, the Faculty of Pain. Dr. Mohabati was awarded a Fellowship of Pain Medicine in 2014 and a Fellowship of Palliative Medicine in 2015, and he's currently the Medical Director at the Sydney Pain Management Centre. Professor Salman Tesfaye is Consultant Physician and Endocrinologist at Sheffield Teaching Hospitals and Honorary Professor of Diabetic Medicine at the University of Sheffield. He is also Visiting Professor at Shanghai Jiao Tong University and Adjunct Professor at Shanghai Hospital, Central Southern University, China. Professor Tesfaye has served as the Chair of the International Expert Group on Diabetic Neuropathy and of NeuroDiab, which is the largest diabetic neuropathy scientific group in the world. Professor Tesfaye was awarded the prestigious Camillo Golgi Prize of the European Diabetes Association for major scientific contributions in diabetic neuropathy, and also the Arnold Bloom Award of Diabetes UK. He's widely published in the field of diabetic neuropathy, including a landmark study in the New England Journal of Medicine. But our first presenter is Professor Stephen Twigg. Professor Twigg is a physician scientist, translational researcher in diabetes complications. He's the Kellyan Professor of Endocrinology and Stan Clark Chair in Diabetes in the Sydney Medical School and Charles Perkins Centre at the University of Sydney. He's also head of the Department of Endocrinology, which includes the Diabetes High Risk Foot Service, and he's medical head of the Diabetes and Endocrinology Research Laboratories at the Royal Prince Alfred Hospital in Sydney. So, Professor Twigg, the podium is yours.
Thank you, Quentin. My name is Professor Stephen Twigg, and it's a pleasure to contribute to this talk in the Nevro Innovation Symposium, focusing on painful neuropathy and diabetes. I've called it Painful DN, current treatments and patient outcomes. I'm from the University of Sydney and RPA Hospital in Sydney. Here are my disclosures. Please note that I'm on an advisory panel for Nevro, and this is part of my Speakers Bureau activity. I don't think I'll say anything that I don't believe in. Clinical case vignette, even in a tight presentation, is a good starting point. Last year, despite being in COVID, I saw Mr. JJ. He'd had type 2 diabetes for 6 years. His A1C had been variable, but it improved a bit over 1% in the preceding months. And he developed, unfortunately, 3 months of bilateral feet and leg pain, particularly in his feet, very disabling, lancinating pain, more in the right than the left foot, but in both. Marked effective even bed sheets, let alone any socks on his feet, to markedly exacerbate the pain. It was worse at night. He had new onset insomnia related to the pain, and he was really developing quite marked clinical depression. And that's only a real summary of his case, but as you can see, not atypical for someone with diabetes and then developing painful neuropathy. And on examination, there were no significant findings of his feet, including no PAD or sensory neuropathy. And we asked ourselves from this, how best can a diagnosis be made of painful neuropathy and diabetes? And secondly, what type of therapy or therapies may be appropriate? They're two key questions in this clinical setting. So hopefully with the brief presentation, we'll address those now. I'm going to talk about the prevalence and burden of disease in painful DN, presumed etiologies, hypotheses anyway. We'll move on to presentation and diagnosis, look at current treatment options, and then innovations in care. Prevalence and burden of diabetes, and particularly painful DN. Well, there's two different types of neuropathy that occur. There's one where there's loss of sensation, we refer to it as insensate, and this is where there's increased risk of callus, corns, pressure effects, foot ulceration, and amputation, unfortunately, in some people. And then there's the painful type where the foot can look completely normal, but it can cause disabling pain. And then some people, unfortunately, have combinations. So it'll be worthwhile being aware of those variations. In Australia, approaching 2 million people we know have diabetes mellitus. And down the left side, we know that the insensate neuropathy markedly increases the risk of developing foot ulceration. Every 2 hours in Australia, we believe there's an amputation occurring due to diabetes. And of course, loss of sensation in the feet increases the risk of trauma. And the majority of people with type 2 diabetes and type 1 with time will develop some form of peripheral neuropathy. In a significant minority, and in this series it was quoted at 21%, but probably in the 20% range, out of all the people with diabetes, about 1 in 5 or so will develop a form of painful neuropathy. And it is often refractory to medical treatment, opioids are commonly needed, and it creates a major challenge for our patients and ourselves in managing it. What then is the etiology of neuropathy in general and painful neuropathy? Well, firstly, neurons are very long in the body, well over 1 metre, those going down to the toes, and they're metabolically challenged. They're obligate glucose users, and if there's a high blood glucose, there'll be high neuronal glucose. So the neurons themselves are under major challenge, can lead to cell death if there's very high glucose levels. And there's also the cells supporting the neurons which are affected, Schwann cells, other interstitial cells. And on the right then, there's not only axonal dropout, but there's demyelination that occurs in diabetes-related neuropathy. And there's multiple hypotheses about how peripheral neuropathy develops: advanced glycation end products, oxidative stress, protein kinase C isoforms, certain polyol pathway flux. These remain hypotheses because at the moment we don't really have metabolic interventions that can target areas on this graph, slide. We think that endoneurial ischemia are affecting capillaries and interstitial basement membrane thickening, and advanced glycation end products are probably involved in causing ischemia and contributing to painful neuropathy. And of course, this is a very complex process. There's abnormalities both in the afferents, the primary afferents in the bottom right there, but there's also disorganisation, reorganisation at the spinal cord level, loss of central inhibition, and also it's felt that there's subthalamic and cortical effects as well in pain mediation. So in a chronic pain, of course, there's multiple areas affected, but the primary afferents are thought to be one site. Presentation and diagnosis, well, the case vignette helped you. There can be a spectrum of symptoms, can be very distressing for the patients. One told me it felt like he'd been shot in the foot. I don't know whether he could reliably say that, because most people thankfully have not had that, but it just shows you how distressing it can be. And in the top right, a clamp feeling on the toe is not unusual either. And it's usually sensory nerves that are affected. It's bilateral, somewhat symmetrical, paroxysmal often in the symptoms, and particularly nocturnal. And that should be compared with things like musculoskeletal causes, lumbar disc disease, which is often much more unilateral and different in its presentation. In the differential diagnosis, and the diagnosis is usually clinical, we have to think about musculoskeletal disease. And then if someone has features of peripheral neuropathy, painful neuropathy, there's many other differentials, and depends on the clinical presentation. But we need to think about monoclonal gammopathies, vitamin deficiencies, thyroid hormone disorder, alcohol intake history. There are other objective tests, of course, for neuropathy, but for painful neuropathy, the nerve conduction studies, quantitative sensory testing are generally not helpful, and we rely upon the clinical diagnosis. There are some autonomic tests that can be done for looking at sweat output, and more a research capacity nerve fibre analysis. And these have 70 to 90% sensitivity for linking to painful neuropathy. So here's a sweat test. That person on the bottom right has marked abnormality and has autonomic neuropathy and also painful neuropathy. Normal result on the top left, the red colour indicates sweating. A colleague of mine, Professor Lee Sorensen, now in Adelaide, she did a PhD with Prof Yu at our site, and they looked at nerve fibre counting. And in the middle there, the lack of nerve fibres is what you see in painful neuropathy. And on the graph on the right, marked dropout. So that typically is found in people with painful neuropathy. They have nerve fibre dropout in the epidermis. What about treatment options and outcomes? Well, I think if the pain is present for many months, it will generally persist for years. We often need to find that we have to start some pain relieving treatment depending upon its severity and if it's affecting sleep, for example. And we do try and minimise fluctuations in glucose. That can seem to help some patients, but if the symptoms are distressing, then they'll need treatment. If they haven't got insensate neuropathy, reassurance is important. So we reassure where relevant that they're not at high risk of foot ulceration, but of course the pain itself needs to be managed. In Australia, we have these foot guidelines for peripheral neuropathy and diabetes, but they're related in particular to risk of foot ulceration or in those who have a current active foot ulcer. And there are guidelines as well internationally, but they're not so focused on painful neuropathy. The RACGP in its treatment guidelines does list the different medicines, the anticonvulsants, the antidepressants, and then some topical treatments, and then opioids, generally a second line. Number needed to treat 3 to 6 people to get a clinically significant improvement, and we often have to use combinations of drugs. Some of them start low and build up. And I'm not going to spend a lot of time on this, but just to say that we need to face painful neuropathy as clinicians and help our patients. At the spinal cord level, then we have multiple agents, I've mentioned them already, that can act at different points, it's thought, and in combination they can be complementary. And here's an example of gabapentin with opioids, an older study, but on the left here, improvements in pain by combination treatment, and on the right, the combination limits the maximum dose tolerated. The reality in painful neuropathy is pain is underappreciated, treatment is often suboptimal, limits, even though there's some PBS options, limit to medication options is an issue. Medication side effects are problematic, and in many, significant pain persists, and practically in everyone, some pain persists, and it's a matter of trying to get it to a point where it's tolerable. I found use of the antidepressants can be very helpful in people that are clinically depressed with their pain, that can treat the depression and help treat the pain. Then moving on to the final point, innovations in care. It's part of the focus of the Nevro series of presentations today. Non-pharmacological options I'm going to focus on rather than longer-acting opioids. That's its own topic. And spinal cord stimulation, we know, can provide great benefit for our patients. You'll hear about TGA-approved products shortly from Dr. Sarah Love-Jones in terms of clinical trials and the rationale for the spinal cord stimulation. But we think it's mainly activating inhibitory interneurons, where most patients, when they receive this treatment, can get marked improvement, according to clinical studies, in their painful neuropathy. So a suggested pathway then increasingly in Australia, we're going to see the evolution includes the spinal cord stimulation, particularly those that are not responding appropriately and promptly to medication interventions, and where we've made a definitive diagnosis, excluded other causes. And so at the end of the day, we need to, whilst curing only sometimes can tend to occur, we need to provide comfort always, and that's no pain, or at least manageable pain. So we've completed in this short presentation the 5 points that I intended to address, and hopefully that's been helpful leading into the broader presentations and discussions. Thank you for your interest, and now I'll hand over to Dr. Sarah Love-Jones and look forward to listening to her presentation.
Hello, good morning or good afternoon, wherever you are in the world. I'm Sarah Love-Jones, a pain physician in the NHS in Bristol, the UK, and it's my very great pleasure to present this randomised clinical trial by Dr. Erica Peterson and team in the JAMA Neurology in April of this year on the effect of high-frequency spinal cord stimulation in patients with painful diabetic neuropathy. And this presentation looks at the sustained benefits at 6 months. So just to have a background, spinal cord stimulation is not new for painful diabetic neuropathy. There have been previous randomized controlled trials with low frequency stimulation and results at 6 and 24 months. This first study in the top graph shows a multi-center RCT with 36 subjects randomized to low-frequency spinal cord stimulation, and the pain responders were 69% at 6 months follow-up. The pain responders definition is those who experience more than 50% pain relief. So that's our definition of a pain responder. The second graph shows the results of 2 studies, 2 randomized controlled trials of low-frequency spinal cord stimulation with conventional medical management versus conventional medical management alone. Again, 36 patients randomized, and the results at 6 months were 56% were pain responders in the daytime and 50% were nighttime responders. Nighttime pain is, as you know, a particularly difficult thing to treat for painful diabetic neuropathy patients. And of note, none of these studies showed any neurological improvements. So the long-term data for low-frequency spinal cord stimulation for peripheral diabetic neuropathy at 12 months reduced somewhat, and we can see here it was 42% of daytime responders and down to 36 pain responders at night time. So there is an attrition rate for low-frequency spinal cord stimulation with peripheral diabetic neuropathy. So this study, the SENSA Painful Diabetic Neuropathy study, was conducted at 18 US centres. There were 216 subjects randomised to either conventional medical management alone or conventional medical management plus 10 kHz spinal cord stimulation. All subjects had painful diabetic neuropathy of the lower limbs that was refractory to conservative treatments. Patients had to have a pain visual analog score of greater than 5 out of 10, as is standard for all spinal cord stimulator treatments. They had a hemoglobin H1C of less than 10%, so their diabetes was relatively well controlled, and a BMI of less than 45. They were all reviewed at the 6-month point by, or 3 and 6 month point, by independent medical monitors. So the responder rate, just to remind you, was a pain relief of greater than 50%. Now, at 6 months, the follow-up assessed 3 criteria here: the pain on the visual analog score, quality of life, which was the EQ5D score, and neurological function. And this included the diabetic foot exam with a Stemos of Weinstein monofilaments. And this is a rapid, easy clinical test to detect peripheral neuropathy or the loss of protective sensation. At the 6-month point, the option to cross over into the other arm of treatment was made available to all subjects, so that if they didn't respond to their treatment in their arm, they could cross over to the alternative treatment. This slide shows how the study flowed. Of the 216 randomised, 103 were in the conventional medical management arm and 113 were in the 10 kHz spinal cord stimulator with conventional medical management arm. There were a few dropouts, a few lost to follow-up in both arms, and after trial in the treatment arm, some patients declined the IPG and some were trial failures. So at the 3-month point, there were 96 in the conventional medical management arm and 88 in the spinal cord stimulator arm, and this was the protocol population. At 6 months, there were 93 in the conventional medical management and 87 in the trial arm. This slide shows the baseline characteristics were evenly matched between both arms of the study. The mean age was 60.8 in the conventional medical management arm and 60.7 in the trial arm. They were matched with for race and the type of diabetes. Most patients had type 2 diabetes, but there were a few with type 1 diabetes. And the duration that they'd had their diabetes and their peripheral neuropathy was also well matched. The primary endpoint analysis at 3 months looked at safety and efficacy. In the per protocol population at 3 months, the percentage who met the endpoint, that was who had greater than 50% pain relief and no worsening of baseline neurological deficits, the conventional medical management showed 5% who met these criteria, whereas the spinal cord stimulator group had 86% of patients who met the primary endpoint of greater than 50% pain relief and no worsening neurological symptoms. Then if we look at pain relief over 6 months using the visual analog score in the lower limb, you can see that the treatment arm, spinal cord stimulator arm with the green graph, the baseline VAS was 7.6, dropping to 2.4 after initial treatment, and then dropping again to 1.7 at 3 months and remaining at 1.7 at 6 months. In comparison, the orange line shows the starting or baseline VAS in the conventional medical management group at 7 and finishing at 6.9, so pretty much static across the 6 months. If we look at each individual patient's pain relief at 6 months, these tornado graphs show that each line is one patient, and the conventional medical management arm, the average pain relief was -2, so their pain got worse. Whereas in the stimulator group, the average pain relief was 76%. These red lines demarcate the 50% reduction line, and you can see that 5% of patients had 50% pain relief in the conventional medical management arm, whereas 85% of the patients in the treatment arm had a greater than 50% pain relief, so they were responders. In addition, we have this definition of remitters. Now, remitters are patients whose pain score dropped to 3 or below for the duration of the 6 months. So that's taken as their pain has they're in remission from their chronic pain. And in the conventional medical management arm, there was only 1% who were remitters, whereas 60% of patients in the treatment arm were in complete remission from their pain, with definition of a VAS score of less than 3. In addition to pain, this study also looked at neurological function improvement. All investigators were trained to do a neurological exam, which included lower limb motor strength, light touch sensation from L1 to S1, reflexes, and the 10-point foot assessment, monofilament assessment for sensation, sensory neuropathy. The investigators were asked if they noted any improvement at 6 months compared to the baseline in motor sensory reflex function without any deterioration in any category. And the result here showed that 61.9% of the treatment arm had an improvement in at least one of the neurological function categories, compared to the conventional medical management where only 3.3% had any improvement in neurological function. You can see here the largest improvement was in sensory function in the treatment group. Patients in the spinal cord stimulator arm were asked to draw a map of where they experienced dysesthesias, such as numbness in the top left, burning, tingling, and cold sensation in their feet. This slide shows a heat map, which is an aggregate of all the patients' drawings of their dysesthesias. So the red area is the highest number of patients reporting, for example, in the top left, numbness at baseline, the feet are red, whereas at 6 months, that reduced to 40 to 60% of patients reporting numbness in their feet. The biggest difference was shown in the burning, those that reported burning in their feet. You can see on the left there, the baseline, the feet were red, whereas at 6 months, the proportion of subjects reporting burning was almost down to 0. So adverse events, all spinal cord stimulator studies, we need to record adverse events. And in the conventional medical management group, there were none reported. In the spinal cord stimulator group, there were some adverse events. Infection is the one that we are interested in, and the rate of infection was 2.7%. Now, when you correlate that with other spinal cord stimulator studies, not in diabetic patients, you can see on the right there that they range from 2.45% up to 4.5%. And then in one of the diabetic studies, it was 8.9%. So this study had an infection rate comparable, on the low end of other studies. And of the 90% of permanent implants, 2 were explanted due to infection, and 1 infection was treated with antibiotics. This study also monitored quality of life improvements, and the graph on the left shows the sleep disturbance due to pain. So this is the nighttime FAS scores, and the orange graph, the conventional medical management group, mirrors the daytime pain scores with no reduction, whereas the treatment arm shows a decrease in night pain and therefore an improvement in sleep. We also measured subject satisfaction, and as you can see, the green lines show that most people in the treatment arm were satisfied, and actually most people in the conventional medical management arm were dissatisfied with the treatment. Part of the study looked at the preliminary health economic trends and measured quality of life improvements with the EQ5D index. You can see the conventional medical management group EQ5D score remained pretty much the same at 6 months as it did at baseline, compared to the spinal cord stimulator arm, where the EQ5D increased and improved quality of life at 3 and 6 months. Just to remind you, EQ5D is 0 is dead practically, and 1 is full life. It's interesting to note that these patients had a higher baseline EQ5D than most chronic pain patients, but it's a different population with diabetic neuropathy. They also looked at opioid reduction. This wasn't a primary endpoint, but they looked at the number of patients decreasing or eliminating their opioids, which was 23% in the treatment arm and 8% in the conventional arm, whereas only 2% increased their opioids in the 10K arm versus 11% in the conventional medical management arm. Also of note, there were fewer visits to the ED and hospital in the treatment arm. At the 6-month point, there was the option to cross over into the other arm of the study. And the criteria for crossover at the 6-month point were having less than 50% of pain relief from your treatment, being dissatisfied with the treatment, and the investigator agreeing it is appropriate to cross over. So you can see in the conventional medical management arm, 88% of those patients met the criteria to cross over, and indeed 82% of those actually crossed over and were implanted with a spinal cord stimulator. Of the treatment arm who were given a stimulator, none of them met the criteria to cross over, and none of them crossed over. So at the study status at the moment is that all crossover implants were completed in late 2020, and all subjects originally randomized to the 10K treatment arm have completed the 12-month follow-up, so we await that. So in conclusion, the study met its primary endpoint data in that large proportion of patients with painful diabetic peripheral neuropathy benefited from 10 kHz spinal cord stimulation. The study met 7 out of its 8 secondary endpoints, showing clear differences from the best available medical treatments. Of note, the only secondary endpoint that wasn't met was the hemoglobin A1C. The 10K spinal cord stimulation has been shown to be safe and effective in the treatment of painful diabetic neuropathy patients with symptoms refractory to conventional medical management. And very excitingly, in this study, it also showed that not only did they not worsen with their neurological symptoms, but they actually showed sensory improvements in many patients with 10K SCS. The durability has been shown over 6 months, and we await the 24-month data and further evaluation of health economic data. Thank you very much for listening.
Good evening, all. Thank you so much for the invitation, and I'm very grateful for fascinating talk by Dr. Love Jones. I'm going to be presenting on the two cases in our practice that we have implanted for painful diabetic neuropathy. Without further ado, I'd just like to go straight to the cases. First one is a 76-year-old lady, Terry, who was diagnosed with type 2 diabetes in 1982. She started suffering from peripheral diabetic neuropathy after 10 years. It only became painful in the last 3 years. She was quite a complex lady with multi-morbidities, including morbid obesity, BMI of around 44, laminectomy in 1973. She had cholecystectomy in 1975, hysterectomy as well, and bilateral salpingo-oophorectomy in 1986. She suffered from psoriasis from 2008 and autoimmune disease, probably Lyme disease, from 2010, and had bilateral vertebral venous obstruction, sleep apnea, repair of leukosis, rheumatoid arthritis, and also an episode of post-herpetic neuralgia. Quite complex, as you can see. For her diabetes, she was on metformin, Tradjenta, and then was introduced to insulin. She was on insulin for several years before saying me, and she had relatively good glycemic control with HbA1c of between 7 to 8 on average. She had a bilateral below-knee insensate painful neuropathy. Pain was pretty intense most of the time. According to her, 12 out of 10 was during the attacks when she had the most intense pain. Other times, on average, 7 or 8 out of the 10. Obviously, very poor quality of life. She was very limited with her ADLs, limited walking. Very insomniac due to the pain, several nocturnal episodes of the pain really interfered with her pain, and consequently she suffered low mood and anxiety. Her GP tried several different medications, including amitriptyline, other tricyclics such as nortriptyline, opioids, non-steroidal anti-inflammatories such as Voltaren and naproxen. Cannabinoids were used at some stage without any effect, as well as over-the-counter medications such as paracetamol and Nurofen. She was regularly seen by her endocrinologist, had a diabetic educator, and eventually was sent to one of our neurologist colleagues who referred the patient to me. The pain was involving those legs below the knee. She had loss of sensation. She was feeling ankle electric shocks and burning feet. I saw her the first time in July, and then following screening, she was deemed suitable for STS. We did a psychological screening as well by our clinical psychologist. And in September last year, she underwent trial. We put 2 Nevro leads from T8 to T11 in dorsal epidural space. And during the trial, which we ran for 2 weeks, she reported that electrical shocks in the ankle was reduced from almost hourly to 1 or 2, or some days none. Burning feet reduced from very intense to a light burn and more manageable. And importantly, her walking distance increased from 75 meters before the trial to almost 400 meters without any stops. And this was something that she was not able to do before the trial. Overall, she felt that she had at least a minimum 50% relief. Objectively, the relief was more than 50%, and the leads were pulled after 2 weeks, and she was very keen to proceed with the permanent implant. So in December last year, we implanted her with 2 leads and the Omnia system. Initial post-op recovery was slightly complicated, as you would imagine, in someone with morbid obesity, long-term diabetes, and other comorbidities. She had some fat necrosis in the buttock, which was recovered. Initially, we thought that this is an infection, but it was not, as the inflammatory markers remained very low. She had full recovery and progressively started to see improvements in both the pain and the function. She reduced her Lyrica to 75 milligram Noctane almost 4 weeks after the implant, completely stopped the CBD oil, and on a graded exercise by our exercise physiologist post-op, she managed to walk 500 meters without having to sit or stop. She was able to do showering, washing, and was mostly independent in most of her daily activities. 6 months down the track, now probably around 8 months, she's very happy with her implant and is doing really well. My second case is Anne, almost similar study. Anne was a type 2 diabetic. Her age was 60, and she developed painful diabetic neuropathy past 10 years. For many years, she suffered from low back pain following a fall 30 years ago. It did not require surgery, but she had significant pain. Ended up having an intrathecal pump following conservative treatment that was failed. She also had multiple other comorbidities, including cardiovascular disease, hypertension, slight heart failure, and was also taking anti-inflammatory medications. Let's stop. The pump, intrathecal pump, did initially help with her back pain, but with increased dose, it lost its efficacy, and it was hard to manage. We did try the microdosing, but it's still not getting much effect for back pain, nor for painful diabetic neuropathy. At some point, she became quite wheelchair bound, wasn't able to stand, wasn't able to walk for more than 5 meters. She was pretty much bedbound at home and needed assistant, 1 or 2 persons to do her activities of daily living. The sleep was pretty poor, and she was waking over 10 times a night. She would often sleep in her chair for a maximum of 1 hour at a time. Due to taking anti-inflammatories for a long time, she suffered stomach ulcers requiring emergency surgery. Following a GI bleed, she survived the surgery, but could not use anti-inflammatories again, and began to feel pins and needles in her feet worse than before. Over time, her feet pain was reported to be 10 out of 10, and she basically became quite incapacitated. The trial of the 10 kilohertz SCS was run for 5 to 7 days. She had leads on the top of T8, top of T9 to cover the T9, T10 disc space within a couple of days, and experienced at least 70% overall pain reduction and 90% reduction of pain in her feet. She was really astounded. Pain from 10 out of 10 went to 1 out of 10 on the feet. Back pain was 50% better, from 10 out of 10 to 5 out of 10. And she started walking again. This is the most important bit. Was able to revisit her passion for gardening and regain her independence. Traveling was not an issue anymore, and she was able to go back to the toilet on her own. Her sleep was also improved. She was able to sleep in her own bed, no longer in the recliner chair, and she obviously was keen to proceed with the permanent implant. The implant happened a couple of months later. Over the last 18 months, she has shown to be pretty functional, walking independently, and is pretty happy with the outcome. I think this just brings it home. The real-world experience pretty much matches the experience through the landmark trial by Dr. Erika Patterson and her colleagues in the US. And overall, we are very happy with the outcomes. These are just the two examples of number of patients with painful diabetic neuropathy that we have implanted since this landmark study. That will do it for me, and I'm happy to hand it over to Professor Tesfaye to continue with his talk. Thank you so much for listening.
Thank you, Dr. Mohabati. My title today is Considerations for Referring Painful Diabetic Peripheral Neuropathic Patients for Spinal Cord Stimulation. We recently, just a couple of weeks ago, published a paper in Nature Reviews Endocrinology, and this review looks at the pathogenesis, diagnosis, management of painful and painless diabetic peripheral neuropathy. And you can see diabetic neuropathy is a distal axonopathy, affects the longest nerves, particularly in the feet. And once it's well established in the lower limbs, it affects the upper limbs. And it is characterized by peripheral and central changes. Previously, it was considered purely peripheral, but now evidence is emerging. In fact, it does involve the spinal cord and involves the brain. This disorder is very common. So peripheral neuropathy in diabetes is found in 1 in 2 people. 50% of all people with diabetes will have peripheral neuropathy after about 10 to 15 years of duration of the disease. And of these people with peripheral neuropathy, approximately half will have painful diabetic peripheral neuropathy. And you can see on your left panel, around 21% were found to have painful diabetic neuropathy in a large cohort, community cohort in the northwest around Manchester region in the UK. And what has emerged over the years is that, unfortunately, many patients do not come with their pain to their general practitioners, simply because they think this could just simply be growing old. Many of these patients are in their 60s. And they think due to arthritis or other things, they don't make that connection between the pain that they have in their feet and diabetes. And therefore, we have to actively look for this disorder in our patients. And you can see in a study from quite a while ago from Liverpool, 12.5% have never reported their symptoms. And of course, if they don't report their symptoms, they're not going to get any treatment. And 40% had never received any treatment for their pain. Now, when we look at the proportion of patients with painful diabetic neuropathy that experience moderate to severe pain, actually, it's not. You can see in this study in Wales, the prevalence of diabetic peripheral neuropathic pain was 26%. So 1 in 4 had painful diabetic neuropathy, but 80% of these reported moderate to severe pain, quite the vast majority. So most people don't have mild pain that doesn't require treatment. Most people have really marked pain that will require treatment. Now, I think it's been said many times, painful diabetic neuropathy affects everything that we do: mood, sleep, energy, mobility, ability to work, social activities, and general enjoyment of life. Everything that we take for granted is affected when you have continuous pain. And what do we do for our patients? And the first line agents are the SNRI, particularly duloxetine, calcium channel alpha to delta ligands such as pregabalin and gabapentin, and the tricyclic antidepressants, including amitriptyline, nortriptyline, imipramine, but mainly amitriptyline. So these are the first-line agents. And if there is no pain relief despite the use of these drugs, NUPSIT guidelines suggest we try the second-line drugs such as tramadol and third-line drugs such as opioids. On the other hand, in the UK, we tend to use tramadol as a rescue medication. The NICE guidance says you start that and then refer to a specialist after that. So these are the first-line drugs. And when we look at how many people respond to these drugs, we've just completed a very interesting trial. It is the trial has been, the methodology has been published, and it was the largest combination trial of all time, and the longest combination trial of all time. And you can see patients who have an NRS or numeric rating scale from 0 to 10, 6.6 at baseline, and with amitriptyline you bring it to 3.8, with duloxetine 3.9, with pregabalin to 4.1. So there is a change, if you like, of around 2.8 drop in the NRS with a monotherapy. And this amounts to around 40%, 50% pain relief. Or NRS less than 3 would be around 30%. So with the monotherapy, the best you can hope is one third will respond partially. And then when you then combine the drugs with combination treatment on your right side, you can see there is a further drop of 0.6 in NRS, and 50% pain relief in around 48%, and NRS less than 3 again in around 46%. So the relief that you get with combined monotherapy, we take all the monotherapies and see a monotherapy effect is found 50% NRS drop. The best we can hope is 40%. In 40%, there is 50% NRS drop, and an NRS less than 3 in around a third. And with combination therapy, you get maybe NRS less than 3 in around 50%. So these drugs have efficacy, but the efficacy is not very good, unfortunately, for many patients. And so the conclusions were that only a third achieved improvement in our NRS less than 3. And when we compare monotherapy to combination therapy, also you can see there is a further drop with combination therapy of 0.6. But NRS less than 3 is found in around half. And unfortunately, these are achieved at the cost of having severe side effects. And you can see these side effects. You can see if we just take the amitriptyline row on your left, you can see 17% will have fatigue, dizziness in 7%, Primal in 21%, sedation in 17%, etc. All these drugs have unwanted side effects. When you combine them, that is worse. So there is now emerging evidence for the use of electrical spinal cord stimulation, and there's been an interesting paper that's just been published, which I'll talk about in a minute. But we were really the first group, and I'm working in Liverpool, that showed that actually spinal cord stimulation is effective in improving neuropathic pain. And as a result, in the UK, this is reimbursable by the government. And what has unfolded in other parts of Europe, and this is data from the Netherlands, you can see that spinal cord stimulation is successful in reducing chronic pain symptoms in the lower extremities in painful DPN for up to 5 years after initiation of treatment. And 80% with painful DPN still use their spinal cord stimulation 5 years after having had it implanted. So it is a long-term treatment, has few adverse events, and finishing off by the recent really large study from the United States of looking at high frequency spinal cord stimulation. You can see at 1 month, 3 months, and at 6 months, there is a significant improvement in pain relief compared to CMM, conventional medical management. So it gives you additional benefit in turning off severe pain. And what are the limitations of the study? There were 3 study-related adverse events, were infection, 2 wound dehiscence, and 1 impaired healing among 5 of 90 patients. So there are adverse events, but they are rare, and the limitations include, it's that there could have been a placebo effect, but the longer the trial went on, this placebo effect is likely to be mitigated. It's not an important factor as long as patients get pain relief. So their conclusion was that patients with painful diabetic neuropathy with inadequate pain relief, despite best available medical treatments, should be considered for a 10 kilohertz spinal cord stimulation. And I think when we look at the algorithm for painful diabetic neuropathy, start with one of the 3 classes of drugs that are mentioned. These are oral medications. You combine them with each other for additional benefit with the option DM trial has shown. And this leaves around 40%, this is a conservative estimate, of patients who will not respond to any medical management, any combination of medical management. And if patients continue to be disabled with neuropathic pain, despite current, conventional management, then we need to consider spinal cord stimulation for these patients. Finishing off, the conclusions are painful diabetic neuropathy patients with adequate pain relief despite best available medical treatment should be considered for 10 kilohertz spinal cord stimulation in a suitable unit with the necessary expertise. Studies are required on long-term efficacy and safety, impact on clinical measures such as improvement in sensation that have been shown by this trial. I haven't had time to show you the results, and the mechanisms of the spinal cord stimulation and its cost effectiveness. Thank you very much indeed for your very kind attention. I will now hand over to Quentin and the panel discussion.
Super. Thank you very much, Dr. Tesfaye, and thank you very much to all our 4 presenters there, all 4 of whom are able to join us. I'm very pleased to say that Dr. Love Jones is also joining our panel. And so thank you very much. That was 4 tremendous presentations, I have to say. I mean, clear and concise, but absolutely packed with insight. So thank you very much for taking the time to prepare and deliver those. And now we're onto the questions. And I think our screen does show on the live feed. So just for the audience, we were there sitting smugly in the green room in our little oligarchy there, talking about the questions we'd answer and all that. And then the ugly spectre of democracy raised its head, and we realised that there was voting on the questions and that we should address those, which is all well and good because we got some great questions there. So without any further ado, I'd like to hand this to the panel. The first question is, who should we refer for spinal cord stimulation? And when should that be in the pathway? Who wants to take a first punt at that and discuss it?
I'm happy to take that.
Dr. Love Jones.
Yes, that's a good question. In the UK, most patients who are referred for spinal cord stimulation would have been through a pain clinic and tried other therapies, such as medications, maybe not in the case of peripheral neuropathy, but certainly injections in failed back surgery syndrome. But I think with painful diabetic neuropathy, maybe there should be a push to see patients sooner. I think they should certainly have tried some medications, and referring to a pain clinic would be the first step. Not all pain clinics provide spinal cord stimulation in the UK, but most pain clinics know their local centre who does. Thank you.
Excellent. Thank you very much. I'm going to ask all our other experts to comment on that question, since it is primary. But Dr. Tesfaye, could I ask your thoughts on that next, because I know you've had some experience in this area too. Oh, you're on mute, Professor.
Yeah, I think this is a very interesting question, and a very it's what we're faced with. We have a huge number of patients that attend our painful neuropathy service in Sheffield. We have a specialist diabetic neuropathy painful service, pain service, which is multidisciplinary. And the problem is you have 1 in 4 of all our diabetic patients have painful neuropathy. And of these, roughly half of them only respond to the best medical management. We're talking about including opiates, and we try to optimize. It's a huge number. In the UK, this would amount to 250,000 people, because 4 million people have diabetes in this country. And so it's huge numbers of patients. Now, it is a difficult question, this, because we can't refer. We have so many patients that we can refer, but would the pain service be able to cope with this? At the moment, we're only referring the tip of the iceberg, if you like, the patients with very severe painful neuropathy who cannot endure their life is not worth living. These are the ones that we're referring. But I think potentially, if these service expanders, there could be a huge number of patients that we can refer to a good unit with good expertise, like Dr. Sarah Love-Jones' unit, places where they have the expertise and can assess these patients and can provide them with this treatment. So at the moment, I'm only referring the ones that are really terribly disabled patients, but I think potentially a large number of patients can, because current treatments are woefully inadequate, as I have shown in our big trial, which we're going to shortly be sending to for publication. And unfortunately, the drugs have terrible side effects as well.
Thank you very much, Professor Tesfaye. Yes. What are your thoughts on the subject?
Well, I think historically, patients with painful diabetic neuropathy are referred primarily by GPs to neurologists. And often the result is that, yes, it is a sensory neuropathy caused by diabetes. But when it comes to treatment, the options really been the same for centuries. Therefore, we need to perhaps resolve these barriers amongst both the general practitioners as well as the other specialists who deal with this type of pain, that there is, in fact, other possibilities and therapies such as HF10 that can actually help with this type of pain. I think we need a major shift in terms of referral paths from the GPs or specialists into multidisciplinary pain clinics.
That's interesting. Thank you. Thank you. And Professor Twigg,
yeah, thanks, Quentin. So, look, certainly I agree with my colleagues. I think in Australia, one of the challenges we have is that access to acute and chronic pain services can be patchy, variable, and sometimes quite limited. And on the other side of the coin, we have some medications, at least, that are specifically indicated under our National Pharmaceutical Benefits Scheme for painful neuropathy. As Vahid said, and as per the discussions, the first point is to make a correct diagnosis, and of course, taking the careful history, it's largely a clinical diagnosis, but then we do not want to exclude other causes of painful neuropathy. But let's presume that we've made the diagnosis correctly. I think a reasonable stepping off point, so to speak, is looking at the key clinical trials, the HF10 trial, for example. And in my experience, if the correct diagnosis has been made, I would have thought one first-line medication could be used and prescribed. But as we know, that requires clinical skill and also titration follow through with the patient. And then I think if we're getting onto a second agent through one means or another, particularly if we're looking at opioids, then we are moving into the territory where the GP or endocrinologist will require help. And if we can get the timing right, maybe we can link in with our pain teams appropriately. So I'll stop there. I hope that's added a bit of nuance.
Thank you very much. Thank you very much. That perhaps actually leads us onto the third most popular question, which is about the collaboration between the different disciplines to ensure that we have the best therapy. If the issue is about patient management and selection and diagnosis, that's going to take a multidisciplinary approach. How can we best assure that? Who would like to take a pot at that?
I'm happy to start.
Dr. Love-Jones.
So that's a good question. And we have recently had a meeting across our teams. We're very fortunate in the Bristol area in the UK that one of our endocrinologists who has an interest in diabetes has a link with the pain clinic in one of the hospitals. So he showed an interest in this paper, and we had a sort of collaboration and a meeting, and it uncovered that he has, or they have in that centre, sort of a list somewhere of about 150 patients with painful diabetic neuropathy that have tried all the medications and they're not really sure what to do with them. So we have, rather than having them all flooding to us, because I think that's the danger, is we've written a referral criteria so that, because it's important that their BMI is right, their HbA1c, as in the study, is correct. And so they're going to filter through these patients, and before they send them to us to make the final selection, because obviously there's all the psychological evaluation behind it as well. So I think that's the way we're going to approach it, in that we will identify these patients, write a referral criteria, and take it from there.
And the patients will be identified in the diabetology centres, you think, and then
Yes,
they're referred on to the pain
Yes.
clinic.
Yeah, I think
Professor
just as a quick note, there are also patients out in primary care who aren't necessarily under the diabetic clinic. So that's another thing which is an unusual referral route for us for spinal cord stimulator to come directly from the GP. But we're looking at how we sort of select those correctly. Yeah.
Right. So finding them in primary care. Okay.
Sorry, Quentin, if I may add just something in full agreement with what Dr. Love-Jones said, that well, I've been lucky to work with a neurologist as well as a group of endocrinologists who share the interest in sort of novel therapies, not just the SCS, but other sort of approaches to management of painful diabetic neuropathy. And this has actually proven to be quite effective in terms of discussions between the specialists dealing with the same patients, as well as coming up with the different strategies in a more multidisciplinary as well as interdisciplinary fashion. So it does work, but needs a fair bit of work.
Okay.
Can I just add to that a little bit?
Yeah.
Okay.
That's cool.
I think we need a much wider discussion. And, in the UK, we have NICE. I've been part of 3 painful neuropathy NICE panels previously. This needs to be looked into very carefully. Instead of just, Bristol, I qualified in Bristol. I went to University of Bristol. It's a great city. But these needs to be standardized. It needs to be discussed, looked at the evidence base, referral pathways firmed up, given the new evidence that there is. And we need to look at, cost effectiveness, patient benefit. There's many aspects that need to be looked at. NICE has a technology appraisal group that looks into all these and comes up with some suggestions. And that's something that we need to do. At the moment, it's very woolly. In fact, in the UK, I wrote the Secretary of State many years ago, about 15, 20 years ago, because spinal cord stimulation wasn't provided for patients with painful diabetic neuropathy. But after our small cohort study, which is published in the Lancet, I wrote to the Secretary of State, it's got to be available for really some needy patients, and it was accepted, and there is reimbursement, but it needs to be a bit more, now that we have bigger evidence, it needs to be looked at and standardized referral pathway developed.
Yeah.
Right.
Great.
And can I follow on with that,
Yes.
Quentin?
Yes, of course.
I mean, our UK colleagues can help certainly provide leadership for us here. In some ways, the population density being a lot higher and the absolute number of patients as well. And we have learned from the other type of neuropathy, the multidisciplinary high-risk foot services. And again, the UK are a bit ahead of us. But in Australia now, we have national standardisation for the multidisciplinary care, which is evidence-based. And that is particularly in the setting of foot ulceration, for example. And I think we certainly do need standardised referral pathways, and we need national leadership in this area with respect to painful neuropathy. So again, I'd be very happy to look towards our UK colleagues who have more of a critical mass of patients. But on top of that, we've heard from Prof. Tesfaye as well and Dr. Sarah Love-Jones that there's a number of very well-established centres in painful neuropathy. And I think in Australia, our links are more loose. As Dr. Mahobati said, we do need to undertake more of an evolution of our referral pathways, and the standardisation is a very important part of that.
That's interesting. Thank you very much, everyone. I'm going to come back to that first question again, because it has a little bit of an angle to it. And that is the specific question that we had wasn't just who should be referred and when, but should we consider it offering 10 kilohertz SCS to PDN earlier in than we currently? So in other words, do we leave this for the very worst patients, or do you think there actually be clinical and patient benefits for offering it earlier in the pathway? What are your thoughts on that? Any takers?
If I may have.
Professor Mahobati.
Yeah, I think the earlier would be the better. And this is from our experience with other painful conditions, any type of intractable neuropathic pain that we have had to employ spinal cord stimulation. Still sort of, there's great possibility that it might work, but the earlier we get involved, and perhaps, I need to say this in a broader sense, that involvement of a multidisciplinary pain clinic would be definitely beneficial. But obviously, we don't have any evidence at the moment to show that, for example, if we get in at 6 months with painful diabetic neuropathy that has failed conservative treatment, would be better compared to someone who's had it for 3 years or 10 years or something like that. So the evidence is still lacking. But I think it's just a general consensus that the sooner we get on top of the pain, particularly given that the role of central sensitization of the nociceptors as well as the somatosensory nervous system, they become highly sensitized, and more problems comes with the more chronic pain. Therefore, it makes sense to get in perhaps earlier. That's my point.
And I'll ask our two diabetologists specifically there. Earlier is better than later, or is there some cause for hanging on?
Shall I start, Stephen? Okay.
Yes, thank you, Simon.
I think we know that the chronicity of pain, the plasticity in the brain. Some papers we've published recently, MRI studies. We do quite a lot of imaging studies. You want earlier seems logical, but I think we need to also really be frank and say, do we have the evidence base for this? We need to do further research. I think patients with early intractable painful and late, look at the outcomes in these patients in clinical trials. We're going to be implanting more of these. So it's part of the research. We can also look at outcomes in these. We need to look at phenotype, patient phenotype, or those patients with irritable nociceptor phenotype, people that have reasonable sensation in their feet but have severe pain, or the patients that have dead feeling in their feet but still have intractable pain, with high VPT, vibration perception threshold. Which ones respond? Is there a particular phenotype that is actually, or does it work in all of these patients? That's another interesting point that we need to look at. I'm particularly impressed by when Dr. Love-Jones presented earlier on that the outcomes in terms of improvement in sensation. There is an issue of a placebo effect, when you're checking particularly QST. They rely on the person's response. But I think it's very interesting. Could this be, is it, we need to understand this better and do further studies. So there is also room for doing, improving our evidence base, how it works and who are the beneficiaries, etc.
Yes.
Can I add to that, Quintin? Thank you. I certainly agree with Solomon's comments. And the only other point is, in Australia, it hasn't been that long a duration that we've had HF10 therapy, spinal cord stimulation, TGA approved, which is our national program of recognising devices. And then, as we've heard, the evidence base for high quality clinical trials is then also really more recent than that, it would be argued. So I think to actually have a pathway of access for patients, and it's a matter of defining who might be able to have access, would be an excellent starting point. And I think the question of, bring it in earlier, I think it'd be nice to be able to have it at all more routinely as an option. And then we've heard there are arguments why in certain patients anyway, it could be looked at being brought in earlier. So I think we might be at a slightly different time frame in Australia compared with our UK colleagues with respect to access to spinal cord stimulation, certainly with reimbursement. We don't have reimbursement at this stage in Australia.
Right. One does have reimbursement for it I'll Professor Mohabati.
I just need to sort of make this point that Australia actually has been at the front of neurostimulation for probably for the past decade or so. 2015, and Australia was one of the first countries to adapt it. Private health insurances actually fully reimburse patients. In the public system, as I understand, there's a limited budget for the use of neuromodulation, SCS, but it is available. For example, in Royal Prince Alfred Hospital, where Professor Tweed works, I understand that it has been used for decades, as well as some other public tertiary hospitals. In private sector, it's actually quite easy to use if the patients have the right level of cover by the private insurance. And the restrictions is not like the US model or some in Europe. It's actually pretty easy once a clinician decides to go ahead with it.
So that's a bit of good news for our Australian colleagues joining, that there is some level of reimbursement.
Just to comment there, Quintin, in practice, the access through the public system is extremely limited for this type of intervention. So I think we have to be realistic, as we've heard private insurance, as Dr. Mohabati mentions, that's a different...
That is very true. That is very true.
With the firm evidence base and these type of meetings and focusing on standardisation and pathways, that can all help, certainly. Yeah.
That's great.
Thanks.
We're running into extra time now, but there's a couple of questions still. So if everyone's still got another couple of minutes to answer, one very specific question that came very high up in it. Quickly, can we use it for other types of neuropathy? This is 10 kilohertz spinal cord stimulation, or is it only for diabetic neuropathy? I think that's a quick question to answer, but
happy to answer that.
Yes.
Yeah,
Indeed.
definitely. Painful diabetic neuropathy is just been sort of added to the list of other approved or indications for SCS. In fact, any type of intractable neuropathic pain, refractory to other types of conventional treatment, is an indication for spinal cord stimulation, such as failed back surgery, or the new name, persistent spinal pain syndrome, pain of the lower back and leg, pain of the neck and upper limb, peripheral neuropathies, complex regional pain syndrome, phantom limb pain, non-cardiac chest pain, just to name a few.
So, excellent. Thank you very much, Professor Mohbati. So we have run into extra time, and there are other questions to ask, but I do think that we have to be mindful of everyone's time limits there. So what I would just like to say to everyone is, to our presenters, thank you so much for taking the time to put together your presentations, for delivering them so precisely, concisely, and with such insight. That was a joy to behold. And thank you very much to our audience for your participation, for the time you spent, and for your interest in this area. And I'll say one maybe slightly slushy thing. Thank you very much to all our clinicians out there for taking the time to increase your knowledge base, for your professionalism in treating patients. Just thank you very much for that. So have a great evening, have a great day, and look forward to seeing you at a future innovations event. Thank you very much, everybody.
Thanks for having me.